I think we should get started. Welcome everybody to the conference. So today we have a special visiting speaker, Dr. Massoumi. Dr. Massoumi is a transplant hepatologist at Montefiore Medical Center for Albert Einstein. Hatef did a lot of his medical training in the New York Medical College system, which is my alma mater. So I didn't realize that. And then did his transplant hepatology fellowship here more than a couple of years ago, right?
Yeah, 12.
I don't want to date you too much. And then we're pleased to have him come back to us and give us a talk on endoscopy in liver disease. So thank you.
Thank you very much.
Sorry.
Yeah.
You can go forward and back and then laser point.
Okay, great. All right. So we live in an era that actually you don't need much introduction. You can just go on any list like this. I was looking for a plumber. I said, let me look, see if Aman did this and just this. So if you need to get more info, right there, luckily no customer reviews. So, yeah. By no means I'm here to say a lot about endoscopy. Many people who are in this place are my attendings, mentors. They taught me how to do this stuff. But I just want to go over some of the practical aspects of how to deal with the patient. Currently, you're in a room with the patient, you're going to scope that patient. What to keep in our mind when we deal with this group of folks. I have no relevant conflict of interest. I will be talking about cyanide-related, hemospray, and statins. None of them have any type of FDA approval for this indication. And it's an open forum. We don't have to necessarily get to the end. So if there is any comment, question, I would appreciate it. I'm going to start with the case. This is a 64-year-old HCV cirrhotic. His child's A. He has 3 centimeter HCC listed for liver transplant. And somebody did a colonoscopy in an ambulatory surgery, found 1.8 centimeter ascending colon sessile polyp. So now they want to remove it. They send it to the hospital. His INR is 1.2. Platelet is 35,000. And the question is, what to do next with this patient? So the first question is, should we screen sick cirrhotic patients for colorectal cancer? So this paper published a few years ago talks about 3 things: polyps, adenomas, as well as advanced adenomas. The dark column is cirrhotic patients, and the lighter column is healthy controls. So if you look at it, easily you get one of these 2 conclusions. Either we as hepatologists are much better endoscopists than average GI, which is probably not true, or maybe true, or cirrhotic patients have much more preneoplastic lesion. So it's important to screen them for colorectal cancer, and that's what we do for a person who has expectancy, which justify this.
Do you happen to know if they control for age there?
They control for it.
Okay.
Yeah. So this is basically a group looking at screening colonoscopy. Yeah. So liver transplant, same thing. Now the patient is transplanted. Are they more prone to cancer?
It's just the healthy controls seem to have like 37% polyps in a healthy population.
Yeah, so this is polyps altogether, meaning hyperplastic, lymphoid aggregates, some sort of bump somebody look at and call it a polyp. This is adenoma.
If you look hard enough, you'll find out.
No, I'm just surprised.
Yeah,
we don't just bother.
But that's a very good question. Nowadays, Qual GI asks you to find approximately 25% adenoma in your screening colonoscopy. That's a quality measure. So if I do 100 colonoscopy and less than 20% of male have adenoma, I'm pulling the scope too quickly out, or I'm not paying enough attention. So the data is not far out of what we know.
Did you see the article in JAMA this week, actually, about doing uppers and lowers at the same time. Actually, only 13% of people in private practice do uppers and lowers on the same day. Whereas,
Facility fee.
yeah, right, because the fee gets reduced. Versus if you do them in a hospital setting, it's like 70%.
100%.
Yeah, of upper and lower at the same time.
As I said, I started with Angie's List. In medicine, I mean, I don't want to get into the politics of medicine, but it's very cumbersome to me that some institutions who provide healthcare are running with the mentality of a supermarket, and then you go to a supermarket, there's a minor clinic. So something is wrong about the economics of the medicine. It's just going to get wronger. So higher risk of colorectal cancer post-transplant. Younger patients get colon cancer. 27% of post-transplant patients with colon cancer are younger than 50. I mean, obviously, some of this is biased by PSC patients who get colon cancer, and they're generally young.
That makes sense with the immunosuppression, right?
And lower 5-year survival. So it's important to do colorectal cancer screening for these patients. So, how easy or difficult is to scope these people? This study look at the prep, quality of prep when you do a colonoscopy. And we were just talking about when somebody come to me and say, I want to become a hepatologist, I do everything to actually push them away, because I think if the intention is strong enough, they would go and they would put themselves into a much more difficult life. Even prep. Among all the factors which shows that patient is going to have poor prep, cirrhosis is on top. So even you will see more poop when you become a hepatologist. So what is in there? You have a sick person, it's not the greatest endoscopy or anesthesia candidate, and it's going to have poor prep for a number of reasons. Methadone, their cognition, taking the medicine, you name it. So it's very important in preparation for the procedure, these patients get enough education, enough hands-out. So you do one procedure, and hopefully that's the one with the right prep. So, post-op risk assessment. This is the, I'm sure you have all seen it. This is the Mayo post-op risk assessment for patients with liver disease. If somebody is going for surgery, you can log into the Mayo risk, assessment thing, and basically you put all those things up there, and it gives you 7 days, 30 days, 90 days mortality. So why did I put this up? Look at a couple of things. What is the ASA score? Just for our younger members of the team to remember, if you're a decompensated cirrhotic, you're ASA. So when I'm not saying every decompensated cirrhotic you should scope them with anesthesiologists. In the past 12 years, I've done it with anesthesiologists. But when you give conscious sedation yourself, you're sedating ASA for patients. So if you feel comfortable with airway management, if they crash on you, you know how quickly you can intubate them, do it. I decline.
No, we don't do that here. It's not even on our ethics.
So even in,
it's not a choice.
Yeah, even in Montefiore, they say, how do you do it? How do you always get anesthesia? I say, because I don't do. If there's no anesthesia, case will be canceled until I get fired. So, this is not the perfect score system. Basically, if you look, there's no rating for the type of surgery. So the cataract and cardiac surgery will be in the same category. However, it gives us a little bit of sense. So what drug to use to sedate people for endoscopy? Obviously, we have all these options. Fentanyl. When we use fentanyl, we should be aware of fentanyl being the new heroin. Fentanyl is longer acting, and it accumulates with repeated dosing. Same as midazolam. The difference is midazolam is a benzodiazepine. We know that benzodiazepine are somewhere in the pathophysiology of hepatic encephalopathy. What is their exact role? We don't know. The GD receptor in the brain. But we know you give Benzo to a cirrhotic patient, he would sleep much longer in your waiting area. All right? So we technically like to avoid it. Diprivan or Propofol, in my opinion, is the best drug, first of all, because its clearance is unchanged. So it's not going to hang around longer. The hemodynamic changes when you give Propofol is hypotension. And the hypotension can be more pronounced in cirrhotic patients. But in our experience, I'm just coding an experience doing this for 12 years. If you inject it slowly, you will basically put everybody into a sleep and wake them up. And my suggestion, I don't have literature on this, is not to mix it with anything else. This is the red wine of anesthesia. Hold it, chit-chat, and sip, and you will be fine. You go and get one of these shots of tequila mixed with it, you're going to be puking, and a couple of other things can happen. So, and that's why, as much as I don't want to meddle on the other side of the bed, if I see that the anesthesiologist is almost playing like one of these celebrity chef cooks, now a little bit of this, little bit, I said that they're pulling like 3 different medicines. I said, humbly speaking, been doing this, just give Propofol slowly, gradually, they should be fine. Neuromuscular blocking agents, obviously, we don't do them on a day-to-day basis, but one thing you should remember is they don't clear quickly in cirrhotics. So we have had a couple of moments when actually ICU or someone gave succinylcholine or one of those drugs, paralyzed an intubated patient, and they said, this is like, obviously, it's a bleeder, it's 2 in the morning. Oh, we might extubate. Because extubating a cirrhotic who was overloaded with the drug and received a neuromuscular agent in middle of the night may not be the greatest idea. We can do it tomorrow. Anesthesia for hepatology patients. What is the number one lung disease in liver patients? COPD. Relation between smoking and alcohol, smoking and Hep C. So we should be aware of COPD. Cirrhotic cardiomyopathy. If in one line, I asked one of the fellows to describe what would you say clinically about cirrhotic cardiomyopathy. You could give a lecture, or you could just simply say the lack of cardiac functional system to adapt to stress. Ejection fraction is okay. They don't have much, maybe a little bit of QT interval elongation. Something bad happened to them, and they don't recover. They go to bad arrhythmias. We have seen it post-transplant. This is, so when you deal with these patients, you want to have someone who's experienced with tachycardia, bradycardia, as opposed to me standing on this side of the bed and try to give the sedation. Unconventional use of other anesthetics, risk of worsening encephalopathy, and this thing, which is aspiration. I never, first of all, many of these cirrhotic patients have some elements of motilization. If they are methadone, if they have it. If they are bleeder, aspiration is the number one risk to them on top of everything else. So if I do a bleeder endoscopy, which we do a lot, patient, you could argue this, but if you ever see that scene when tons of blood and clot comes up and then your patient goes blue and you lose a patient, you will remember it for the rest of the life. So we push for intubation. If the patient is super stable, sometimes I tell ICU or anesthesia, you go in, take a look, there's blood in the stomach, you're going to pull out and you intubate the patient. So you said platelet count was 35,000. Is that enough to do this polypectomy? So this paper nicely talks about hematologic changes in cirrhotic patients. What to do, what not to do, and how much platelet we need. So 60,000 platelet is what you need to do most procedures. However, there are risk factors for bleeding. There are some co-founding elements involved in view of bleeding risk. And I want the fellows to remember two things out of this. One is renal failure, and one is sepsis, because the sepsis lead to worsening of coagulopathy. So if you have a platelet, we do taps all the time with platelet, 40,000, 50,000, 35,000. Two things I always say is platelet under 25,000 is probably not better. So if you have a platelet count of 20,000 or 18,000, there's probably a component of consumptive coagulopathy or a component of whatever you want to call it in hematology. I call it mini DIC happening. So your patient is at much higher risk of bleeding at a platelet count of 17,000 versus 27,000.
Have you been using TPO, those TPO agonists?
Yes,
Free?
that's my next slide. I mean, I don't use them. I only one case, but I go over the literature. So how to check these people to see if they're pro-bleed or not? You have CBC, you have platelet count, you have INR, and I'm sure you're bored by hearing that none of these things are that reliable. So we have a new test called TEC, thromboelastography. It gives you a panel of numbers which are reflective of clot formation. So it's the fancy, sexy version of those who are old enough, remember, bleeding time, BT. So, however, it looks more than just what BT would do. This paper, published in Hepatology, picked patients with platelet count of below 50,000, INR of more than 1.8, and randomized them to two things. Either we look at the TEC and transfuse based on the TEC result, or we do hospital routine criteria. And if I ask you, what is your hospital routine criteria? There's none. If you ask me, what is your routine criteria, forget about the hospital, I say none. It depends on my mood that week, whether I have to make it to my kids' swimming lesson, and a bunch of other things. So a fellow says, how did you decide with 2 units of platelet? I didn't decide, it just came from my extrapyramidal system. So that's called hospital routine criteria. So what was the difference? If you go with TEC, 30 patients, you only transfuse 5 out of 30. If you go with a standard of the care, you transfuse almost everybody, isn't it? With something. If the INR is more than 1.8. You give 4 liters of FFP versus 17 liters, 4 gallons, and much more platelet. So what we learned from this is one thing. TEG might be helpful, and the SOC, a standard of the care, sucks. Basically has no evidence, and we just pour patients with some sort of products. And you might ask, is that practical to get this test done? Just for your info, this guy, Rui Yang, is an orthopedic surgeon. So if an orthopedic surgeon can get a medical test done, anybody else can. So this was a patient of mine going for hip surgery, and I wrote in my note just to look a little fancy. I said, check TEG. Interestingly, they did check TEG. And based on this, with a platelet count of like 70,000, they did a major hip surgery with nearly no bleed. So TEG is reliable. So you want to rise. So that platelet was 35,000. Those who do colonoscopy here know that if you cut a polyp, yes, they can bleed. But more importantly, they can bleed a week later. And if you give platelet to a 35,000 platelet patient, your platelet count is going to drop within 5-6 hours. So it's not going to help you a week later. So what would you do to push the platelet up and keep it up, at least for a week? You can do thrombopoietin analogs. Currently, there are 3-4 of these drugs. I'm going to review the data on AVA Thrombopag. So what they did is they basically gave this medicine. It comes as a pill. They gave the medicine for 4 days, 4 to 5 days, and then the platelet count goes up. They did the procedure between day 10 to 13, and the platelet slowly comes down. You see the pick is pretty shallow. It didn't push it a lot. The reason you don't want to do a dose which pushes it a lot is because you can get significant thrombocytosis. So in their cohort, less need for platelet transfusion or rescue intervention in AVO thrombopack group. Number one. Number two, 3 patients had platelet count shooting to 200,000. No thrombotic event happened, but you have to be aware of that. You push somebody's platelet from 35,000 to 200,000, a lot of things can happen. And without going into a lot of details, I would say about this. This is the older sister of this drug, L-Thrombopac. You remember when I was just telling your fellows that Hamid Kalia believes the hepatologists should be divided into pre-interferon and post-interferon era. So we were giving Pegasus to somebody with platelet count of 35,000, and they would drop to like 10,000, and we're hoping that L-Thrombopac helped them. I was a PI for this in Montefiore. I don't know how much of this I can rely or not. Never registered a single patient because I felt never. My ethicometer kicked up, and it doesn't do it that often, but did it in this one. This study was stopped with no clear explanation. They believe, because you get the PI things that somebody had a thrombotic event in their left ovarian, vein, and it's common. You don't see it, or like left carotid is common, so we don't see this. So they believe they used too much drug and had overshoot of platelet. That's why they had more thrombotic events. It's an approved drug, it's used in ITP, but the company never went for FDA approval in cirrhosis. So all I say is, be careful how much your platelet goes up.
Yeah, I
And
think
it-
there were a bunch of portal vein thrombosis too. That I remember. I think it was Oftal presented at ASLD, right?
Yeah.
There was a highly significant number of.
So portal vein thrombosis is one, but left carotid artery events is little off. So I was not having a lot of issues even with portal vein thrombosis. I had issues with other embolic events. So one thing you do, if you use this drug, is a good tool, is available, limited criteria, you have to rule out low portal vein flow. So every single patient who goes on this has to have a Doppler, make sure they don't have a low portal vein flow. In their study, less than 10 centimeters per second. Yes.
Deb, can you comment on the assumption that these TPO trials make, which is that you need to give anything to these patients,
Okay.
and the fact that the type of procedures that they're doing are quite various. I mean, I think there are certain procedures that we see,
Yeah.
transfer liver biopsy or TIPS performance or some more invasive things that we would be less argumentative about with our colleagues versus paracentesis, for example.
Yeah. So excellent question. Number one, even tips. If you believe in tips, you're going to believe like that. If you're doing tips, you're not concerned about delayed bleeding. So the only place I give a role for them is
Unless they
delayed
puncture
bleeding.
the capsule.
Even if they puncture the capsule, they're in the hospital, you watch them, they often puncture something. So the platelet transfusion might be just as good. In their trial, Jim is right. They, for example, some of their patients, were diagnostic colonoscopy. What do we need to increase somebody's platelet for diagnostic endoscopy? We do a lot of paracentesis. Why you need to do it for paracentesis? To me, the indication is very limited. You're going to ban esophagus in a person with platelet count of 20,000, and you're afraid of a week later, patient bleed from post-banding ulcer, feel free to do it. You are going to do a right colon snare polypectomy Even if you put a clip, these guys can develop ulcer due to the heat that you use and bleed a week later. Do it. But if you're going to do something right now, you could just give if needed. So yes, if you look at their table, they divide it into moderate invasive, low invasive, and high invasive. Majority of the cases where actually the drug was given for low invasive procedures, then no average GI or hepatologist would give play at all. Forget about another
Actually,
drug.
though, there was a big difference between GIs and liver people. GIs, between the coasts,
Yeah.
flyover states, they use platelets all the time.
Yes.
They're afraid of this. But the liver people just don't bother because we don't think it's an issue.
Yeah, exactly. I mean, I never questioned their judgments.
And
In our own instance,
some hospitals, particularly community hospitals, won't allow you to do a procedure with less than 50,000 platelets. And that's, I think, our IR people have a 40,000 rule. But the vast, we kind of forget about the flyover states and the community hospitals. It's like those GIs are using platelets like all the
and
time.
chocolate. Yeah, you're right. And then like people give FFP and repeat the INR stuff that we never do. I mean, I think if you give FFP and INR corrects nicely to a very good level, you should think that this might be actually a little bit of nutritional instant liver thing, because usually it jumps up next day or next hour. So you are doing a procedure. I always say these are the things you check. Patient is laying down there. I'm doing a procedure. What type of procedure I'm doing? What type of indication you have? Patient's overall status, urgency of procedure. Can you handle the complication? If you're in a community hospital, excellent point, and you do something, and the patient starts bleeding, and now you need an aggressive IR to do an angiography for you, and there's no such thing available, maybe we shouldn't do that procedure. Can you handle the complication? Can patient handle the complication? And can hospital handle the complication? So another case, 67-year-old, alcohol-related cirrhosis, child's age, abdomen 3, INR1, platelet 152,000. So guideline says cirrhotics, ASLD guideline should be screened for varices. Does he need to be screened for varices? Now we have more data. This paper, they look at, this is called Baveno 6, favorable and unfavorable patient. Baveno 6 favorable patient is a person who has a platelet count of more than 150,000 with elastography point of less than 20. This is unfavorable. If you look at the data, in the favorable group, low risk group, you barely get high risk variants. So if the platelet is more than 150,000 and your fibro scan point is under 20 pKa, you don't have to necessarily do upper endoscopy. They just published a paper in Gastro. They look at the viral patients post and pre-cure, and it stands the point. Endoscopy is not such a difficult thing, but if you feel the patient has COPD, I really don't want to expose them to any risk. Platelet more than 50,000, elastography under 20, don't do it. 48-year-old, NASH cirrhotic, upper GI bleed, come to the emergency room, had SPP last week and received a full course of antibiotics. Child B, ascites, platelet 42, INR 1.8. EGD showed large esophageal varices. They get kind of extended about 1.5 to 2 centimeters, as good as your eye can measure centimeter, into the lesser curvature, ton of blood there, and you're asking yourself what to do. I purposefully put some of these numbers here to remind everyone about two things. Remember, platelets of 42,000, we feel comfortable to do a lot of things with them, but just let's go back. Two things make them more pro-bleed: infection and CKD, or acute kidney injury because of endothelial dysfunction. It's not just a matter of, people don't bleed from esophageal varices because of low platelet. I have a patient with 40,000, we just did a workup for transplant. He has, usual my luck. He has triple vessel disease. They put a stent now. He's an aspirin, Plavix, and cardiologists keep calling me. Is it okay? I said, it is okay. If you bleed from anything, you would bleed from an AVN, not from varices. Usually AVN bleed wouldn't kill. So, okay. Because when I say it, people usually bleed. Yeah. So what to do? Should we go and band the esophagus? Do it extend a little bit into the lesser curvature? Should we do this, which makes me crazy, but some of people do it? Since patient is not bleeding, terminate the procedure and repeat PGD after giving erythromycin. Use bleeder scope and clear fundus to make sure there is no GOV2 or IGV. Do a TIPS or just band it. You're there, you see a big varix, clot sitting in the stomach. You're asking yourself, what should I do? And this is my answer. You see this monster? You have a band, put it on. Because by the time you pull out, get your bleeder scope, the bulb doesn't work, and something happens, and you go back, and now it's some sort of Quentin Tarantino scene, mud up to here. And you don't know how many times I cursed myself. With all sort of words, saying, and I let it go. Now the patient get Blakemore, rush to the IR, get the tips, and I remember this story. So why I say that? What else could be in the fundus that you miss? Gastric varix, you're not going to do anything to it. The only fear is Dulafoy lesion. So if you're that unlucky that the Dulafoy is sitting there on top of everything else, that'd be unlucky. But we usually band it. So if you band it, the esophagus, can the GOV1 bleed, that theoretical thing that you band upstream and the blood gets rushed down? So not the greatest article, not the highest impact journal, has a nice name, but is one of those low impact things. So, but they look at it. They band it, esophageal varix. They look, number one, they have no bleeding from gastric varices, and they found the risk of those varices getting bigger was not that great. This is Pierre Simon Laplace. He is, anybody knows him? Yeah, he was basically, the Laplace law. Yeah. So he was at the time of Napoleon Bonaparte, he became the interior minister. He was a physicist, a scientist, one of the greatest scientists they believe existed. And Napoleon made him actually his interior minister for about 6 months. But then after 6 months, he fired him because he thought he's too scientific. Sounds very familiar story. Apparently, he sent some pigeon at 2 a.m. to let them know that he's fired because back then there was no Twitter. So, but what did he say? Laplace, this is what he said. Laplace law. So wall tension, which is your Achilles tendon. Wall tension is basically based on transmural pressure that you cannot measure when you scope. Radius is the size of the varix you look, and wall thickness. So when you scope, you should remember Laplace. If the varix is big, which is now the guideline, you are no longer looking into grade 1, grade 2, which people, many years ago created it based on inflation. Basically, you put air, and if the varix collapses, you call it grade 1. Very little science. I tell the fellows, just call it juicy or non-juicy. I understand it a little better, because even that once in a while, there's a GI attendant that calls me, man. I said, juicy, no juicy. They say juicy. I said, just band. Don't wait, just band. So, however, 2 things, size and whether the wall is thin. And wall is thin is the reddest spot, or varix on top of varix, and the size is more than 5 millimeters. So briefly, the latest guideline talks about how to prevent these things, and I want to get one message out of this whole slides. This is primary prevention. For primary prevention, beta blockers, no tips, and if there is no bleeding, there's no need for repeat EGD unless something changes. Patient develop further decompensation, portal vein thrombosis, something. And no need for combination of esophageal variceal ligation and beta blocker. However, take-home message, if the person has already bled, and now you're scoping him, you should scope them within 12 hours. This is written in the guideline. So let's get ready and we will do it Monday. You have a medical legal thing sitting right there in the guideline, 12 hours. And the sooner you do it, once the patient is stable, the better. EVL with beta blocker. If you cannot give beta blocker, no matter how good you keep banding these people, they are at risk for rebleeding. It's hard to believe that beta blocker is actually the mainstay. It's the mainstay. And if you cannot give beta blocker, intolerant to BB, you get tips. You got to have a bleeder has to have two modalities to protect them from rebleeding. Some of the newer, fancier stuff, chemo spray. Chemo spray is this tool. It comes as a gun, as a catheter. You basically put the catheter in the scope, like any other catheter. The channel has to be air dry. So you flush the channel with empty syringe. And then examples, this is like they put a couple of clips, patient is still bleeding or they get nervous. You spray the powder and that's what you see. So it works magically for non-variceal bleeder. It's a band-aid, so they can rebleed. The question is, can we do this in cirrhotics? So this paper was published this month in Gut, a very high impact journal. Frankly speaking, I would say this study would never, ever pass IRB at this point in your institution or our institution or anybody's institution. So what they did is they get upper GI bleeder, variceal, they scope them. If they see active bleeding there, they do something. If they don't see it, they randomize them to two groups. One group you pull out and give basically you give vasopressin or octreotide for 12 to 24 hours and go back and scope and then bang. The other group you spray on top of the varix and then go back in 12 to 24 hours and do it. I mean, it might be me, but I just you scope a bleeder. You see the varix is sitting there. You pull out. I don't know how you can justify it. So what they found is that the study group had much less death than control group. So you can imagine, you can think that the tool works. Should we do it like this? It's madness. I mean, in my opinion, you see the varix is sitting there, why you shouldn't ban it. But it's one of those tools which could potentially come to your salvage at some sort of clinical scenario. Other salvage options, we all know about Blakemore tube, but you all heard about esophageal stent. In this paper in 2016, they compared covered stent for a variceal, esophageal variceal bleeder who doesn't stop bleeding versus Blakemore and the stent D. I remember when they presented this in 2006, when I was a fellow here, we thought these people are joking. It was from Korea. They put a stent, and 2 weeks later, they went and pulled it out. And since then, this has been reproduced, and is a specific type of a stent for it. 36-year-old PSC patients come for colonoscopy, mild occasional loose stool, no rectal bleeding, colonoscopy, go to the sigmoid. It shows a little bit of inflammatory changes. He has very mild symptoms, and now you have problem with sedation. Should you stop the colonoscopy at this point saying that, you know what, is it UC? That colon is pretty fine. Why should I keep pushing it? Should you push it or you shouldn't push it? If you look at this study, Keith Linder and his, Dr. Sandberg and his team wrote this. It's very interesting. They believe PSC IBD is not actually IBD. It's a different disease. Because if you look at their UC, this is PSC UC. 32 patients, half of them have rectal sparing. In real scenario, if you get into the rectum and there's no UC, there's probably no UC anywhere else, unless you think that it's magical effect of some hemorrhoidal steroid creams that cool down the rectum and everything else, and you're blind and you only see the rectum and not anything north of rectum. But here, it's a different disease. So if you're dealing with PSC UC, you have to remember 3 things. They are often with low level of symptoms despite having horrible colitis, number 1. Number 2, colitis is more prominent in the right side than in the left side. So if the left looks good, you have to go to right. You can miss cancer in right. But you get to the right, and you're a first-year fellow in July, and you cannot get into the terminal area. Should you call this attending second-year fellow or do something or cry? No. The disease is almost always colon. So if there's no colon IBD in PSC, there's no IBD. And they're at the risk for colon cancer. So, a couple of other things. Portal hypertensive gait. Sorry. Other options presented in the literature for gait, besides APC, you could band them. You could do RFA, which we have done for a few of our refractory gait patients. It's a probe. The advantages, instead of burning pieces by pieces, this is the probe. They put it, boom, boom, boom. And our experience with about 2-3 cases reflected the same thing. We did not have a disaster, and the patient's overall clinical symptom, anemia basically, and need for transfusion improved. Barrett esophagus, if you are unlucky enough to have a cirrhotic patient with varices and end up having also Barrett, what to do with it? Again, is Barrett going to kill him? If he's a person who has no path to transplant and is a child with cirrhotic, you know what's going to happen. He's going to die from the liver disease before from Barrett. So you just leave it. But if this is a person that you think, no, is a child A, has significant portal hypertension, what is a child A? So he's not going to die within the next 5 years, and you think, and you are not going to be able to biopsy this thing. So what you can do, starting from here, coming to here, what they are doing? Banding. In several banding sessions, they literally did EMR of the mucosa. Banding it, and it's going to flop off. And actually, if you can look, this is pre-banding. This was published in GIE, gastrointestinal endoscopy. Here, very little disease left. So that is one of your alternatives.
Actually, I do cytology on those. And if cytology is okay, then I just let it go.
Good.
We just keep watching it.
So you feel comfortable to brush it.
Yeah, you just got to be careful. The brush has a point on it, though, so you try not to
it's like a
stick it into the varix.
That's what, it's just, yeah, don't put a needle in the varix. No, that's what Larry Brand said. Because I said, I don't have enough length of gut to do it. He said, no, he has done it, and it's no problem, you can just brush it.
I do it all the time, except the nurses hate me because they hate to do the wire clippers to cut the brush off. That's really...
Hate and love is a different subject. We can talk about it. So, gastric ectopic varices. Take home message. TIPS is not as effective. If the varix is not in your esophagus, you may not get a full result with TIPS. It's more prevalent when there's extrahepatic vein thrombosis, and you usually need 2 interventions to handle this. Management of gastric varices. Do you guys do glue here? Cyanoacrylate? Yeah. So we don't do any cyanoacrylate, so I have to say kind of biased because our interventional people don't like it, and we usually, they just don't do it. If you go to NYU, probably Greg Haber does a lot of it, but which one is better, BRTO versus cyanoacrylate? This paper was published a few years ago. They look at the complications And if you look, cyanoacrylate had more complications than coil. This was a study done where they did CT chest for everybody, regardless of symptoms. So this is not necessarily a clinical complication. It's CT chest showing blue in the lung. Only one patient actually had clinical PE in this. This paper, just a couple of months ago, they again looked at endoscopic cyanoacrylate versus BRTO. More rebleeding in endoscopic cyanoacrylate. This has been shown in another study. Same mortality, but I'd like you to, if you're a big fan of p-value, don't look at the last line. If you're like me, look at the last line.
Okay.
In endoscopic cyanoacrylate, 1 procedural death. In BRTO arm, 5 out of 71, 1 out of 90. P-value did not make it. So they said it's the same thing. Just some sort of signal there saying that BRTO might be a little bit riskier procedure just to perform. We had excellent experience with BRTO. It's just because one person does most of it, and he got pretty good at it. Let's put it this way. Portal hypertensive vaginal bleed, and that's the guy who does it. So as you can see, this was one of our patients. This is the barracks going from here all the way down to her vagina. She came in with multiple vaginal bleeding, which was labeled as, at one point, as DUB. Eventually, we realized that, no, this is just varix. Look at the varix in the vagina. Just for the GI fellow, when she was bleeding, he couldn't get a hold of somebody to come and quickly put the scope in the uterus. So they asked me to do it. And there's another one of those things. Don't intubate the wrong orifice. Though it's very same concept. Though the patient was dying, I declined to do it. I got the GYN to come in. They went up. They actually saw the lesion. But look, we put this much coil, and she was still bleeding. That's an example of you need 2 things. So then they went up there. You see that? They stented the splenic vein because there was a thrombosis there, and she stopped bleeding, and she died of alcoholic liver disease, unfortunately. So, summary of the talk. Pretty much, you need 60,000 platelets to do most procedures. However, if your patient is infected or has kidney failure, the risk of bleeding goes up. You may need a little bit more platelet. Platelet count under 20,000 is not necessarily entirely due to liver disease. There is a secondary hematologic event happening, so we want to be careful. TEG, thromboelastography, might be a helpful modality. We had a patient, we did a colonoscopy for screening before we list them. He had a 3mm polyp. I actually want people to write it. They biopsied the 3mm polyp. He bled to shock. When I heard that, I came on service on Monday. I said, they biopsied a varix. They said, no, it's tubular adenoma in pathology. I said, then I don't know what happened. So we did the whole 9 yards of workup. Everything besides a little bit of lower factor 5 was normal. TEG was normal. He had multiple tooth decay. We sent him for tooth extraction. They extracted his teeth with FFP, with platelet, with cryo, no chase central. Just honestly blaming myself, maybe I should have given that one. He bled 2 liters, and they couldn't stop it. He developed massive submandibular hematoma and died of infection related to hematoma, with a platelet count of basically about 90,000. The hematologic complexity of these people are very difficult to understand. If somebody wants to make a career, is an open field. Ectopic varices usually need more than one intervention. We talked about colorectal cancer surveillance. PSC patients are often symptomatic, and you cannot, is not right, remember to ignore the right colon. You got to get to the right colon if you want to rule out colon cancer, but you don't have to get to TI. Banding may be helpful with Barrett in case You end up with achalasia, which we had one case with varices. There is a role for, obviously, that patient. We were basically our interventional GI was doing US guided what is this thing we inject for skin?
Botox.
What?
Botox.
Botox. We did Botox every 6 months, but then I did a little bit of homework and I saw that sclerotherapy actually has been reported as a way to treat achalasia in patients with esophageal varices. All right, I'm done, and the panel is open if anybody has any question or comment.
Jeff, it's good to see you. Great, fantastic talk. So the coordinators always come to us, the pre-transplant patients. You know, Mr. Smith needs his colonoscopy to complete his evaluation.
Mm-hmm.
I mean, how stringent do you guys at Montefiore in dotting all the I's and crossing the T's? I mean, I think we're a little bit more pragmatic, and we take a chance and we waive the procedures in a lot of these patients. We are concerned about how they're going to do.
Obviously, depends on where they are. I mean, if this is a patient listed for transplant, child's A for HCC, no big deal. Decompensated patients, I always say, do it, just don't push it. We have done also CT colonography because we do have a radiologist who happen to read CT colonography normal. Finding a radiologist who reads things normal is pretty difficult. But they actually do a good job. They go over the prep, and we have done a handful of them. And even Tom Allman believes that they do a very good job with the CT colonography. I scope most of these patients. If your question is about somebody, just actually my patient, who has currently INR of 3, platelet count of 40-something thousand, she's listed. If you do a colonoscopy and she got barrel trauma in the right colon and did a tear and translocate a couple of E. coli, she's dead. We said we will deal with it after the transplant. So completely per case. If it end up that she has something sitting in the right colon, in fact, her right colon is little thick, but almost everybody's right colon is thick. I was just quoting Scarface, Al Pacino in Scarface, as his famous statement: anything over the ground is doable. So if she ends up having colon cancer immediately post-transplant, I will be able to handle it. If we go in and perforate the patient or microperf a patient with meldophteri, you basically kill the patient. And we had one patient we lost to this, not in our own institution. They tried to remove a polyp in the right colon. He was our patient listed. They microperfed him. It took a day for them to know. It came in with platelet. We lost our patient, a 59-year-old man. So it's per case. Yeah.
There was a paper actually there's a Dutch paper I think in the Journal Club in hepatology the past couple of months. So the Dutch group, 900 patients, any patient listed for OLT, all got colonoscopies. 40% were like B and C, child few. 25% were HCC, and then they looked at the absolute rates of neoplasia. So only 2 patients out of the 900 had cancer. Both of them were stage 1 or 2, so treatable folks. And then 5% had advanced adenomas. But then there was an increased risk of, I believe it was renal failure and infection or renal failure and bleeding in this group. So it kind of questions the utility of some of these hospitals. So it's definitely a case by case now.
Case by case is a debate. People are now debating if HCC would give you, if you transplant HCC patients out of criteria and give them 70%, 60%, 75%, 5 years survival, beside the fact that you're pulling an organ, it's not such a bad idea. For an advanced cancer, they are giving chemo for much less thing. So if you transplant, save a life, and the patient has colon cancer, and you go after the cancer 6 months later, yes, cancer might be much more aggressive, but as you said, colon cancer is now not that difficult. I would be much more concerned about probably the ugly-looking pancreas lesion, because if you miss that, you're going to end up with 1 year, 100% mortality, but colon not that difficult.
Jeff, what are your thoughts on doing banding? A patient that needs banding, not just sort of cheap prophylaxis, who are on Coumadin or some direct oral acting
Okay.
anticoagulant.
Yeah. So I don't have experience on that. I have a couple of Montefiore patients who are on NOACs, and I did not have to ban them, but I bridged them in case they needed to be banned. There's one paper from Pittsburgh about procedures on anticoagulation type of things. Unfortunately, has no Plavix patient in it, neither a NOAC. So even on Plavix, we become kind of like more concerned. It all depends on, yeah. Have you done it?
Tom and I have share a patient where we've done that very carefully.
On Coumadin? Yeah. I mean,
And we try to minimize the post-band ulcer issue.
is it a cirrhotic or non-cirrhotic portal hypertension?
Non-cirrhotic.
Non-cirrhotic. I mean, first, because I don't give Coumadin to any cirrhotic to begin. So non-cirrhotic portal hypertension or child A, again, another thing, when fellows call me and say, oh, there's a bleeder in the ER, I always go in. I'm such a busy person that I rather to do at 5 a.m. than 7 a.m. because 7 a.m. means my day is completely screwed. So the sooner a patient is stable, we do it. But the first question I ask always is this, child is cool. Child A can handle anything much better than child B and C. So if they come with a bleeding, you're right. I mean, if you stop the Coumadin, what you are going to do with post-banding ulcers. So if it's a child A and even like ooze from the post-banding ulcers on Coumadin, probably would survive. If it's a child B or C, would probably die.
Okay, I think we'll have to end here. Thanks again.
You're welcome. Thank you.